welcome. My name's Kyle Hogarth. I'm the editor of the podcast section. We've got a new series that we're going to be doing. We're going to do some videotaping of people that we're lovingly referring to as giants in chest medicine. Professor Barnes probably doesn't need much of an introduction. If you are involved in pulmonary medicine, you're familiar with both him and his work. But he is the head of respiratory medicine at Imperial College London. And he was kind enough to join us today while we're here at Chest. I think he just flew in last night and he's flying out again tonight, so I feel very honored. I think he came in just for this. He had no other meetings. Professor Barnes, thanks for joining us.
Well, thank you for inviting me.
Absolutely. So let's get started. When we had discussions on the editorial board about the purpose of these kind of interviews, there were a couple different things I thought we could address. And actually, I want to start off real simple. Tell me what you would have done if medicine was not going to be in your future. When you were a boy growing up, what did you want to do?
Well, it's an interesting question because I always wanted to be a doctor, and I don't know why, because no one in my family was ever a doctor. But I thought doctors had a pretty nice time because I knew some doctors, and they used to go and play golf a lot, and they went on nice holidays. And then at the same time, they had an interesting job. Yeah. So I never really considered any other career. And so what I studied at school were the subjects that you needed to get into medical school. And I've never regretted that.
That's excellent. What about, what drew you then into to pulmonary medicine, respiratory medicine?
Well, that was a chance thing. I was training at Oxford University, at Oxford Clinical School, and we studied all of the different topics related to medicine, and I found it very difficult to choose between them. And so my original aim was to be a general physician, covering all specialities, an internal medicine specialist. Yeah. But as you know, this specialty's gradually disappeared because people have become more specialized. So it got to the point where you had to choose a different specialty, and I really couldn't decide on this. So I was applying for the next level of training, which is the one before you become a sort of accredited specialist, which is called a senior registrar post. And they were always in a particular area, like cardiology, gastrointestinal. So I applied for several of these posts in endocrinology, cardiology. I think I went to gastroenterology, and I turned up at the interview and I never got the job. And then I went to one in respiratory, so it was quite a chance thing, and I didn't get the job as usual. But the professor who became my mentor, Neil Pride, rang me at home and said, "You didn't get the job because you haven't done any research, and you really need to do research." And I said, "I really don't want to waste my time doing research because I want to stay in clinical practice." And he said, "Well, look, I can get a job for you at the Hammersmith Hospital," which is where he worked, for 6 months in research, because I know they're looking for someone to do a project in asthma. So I said, okay, well, I'll do it because I really need to get the next step in my career. So I took this job, started doing the research, which was into the pharmacology of asthma. Right. And I got totally hooked by research, and I've stayed in research ever since. So it was really quite a chance thing. And what I say to people now is that you shouldn't predetermine what you want to do, because you have to really take advantages of opportunities that arise.
I think that's, we're going to come back to that, because I think that's absolutely fantastic advice, and I'm struck by how often when I talk to people who I view as mentors who will tell me that they almost indirectly fell into the field they're in, but maybe instead of that, it's more they went into everything with an open mind and something just grabbed them and they ran with it. Well, thank goodness you didn't make it into GI.
Well, I might have been happy there.
No, we're better for it. Thank you. Thank you, someone back in GI who said no to you. So why don't you then take us through your research? And I would love for you to, actually, why don't you summarize everything for us? And I take that back. I mean, meaning like, okay, let's recite
Briefly.
every thousands of papers. but I guess what I would say is for people that might not be familiar with the scope of your work, could you take us actually through the evolution? And I find it interesting because, of course, airways diseases have evolved, both our understanding, the pharmacology, and everything else. But you were there helping to lead that charge. So I would love to have your perspective on that.
Well, my first research was in asthma, and it was the post that I was referring to at the Hammersmith Hospital,
Right.
Where I worked with the head of clinical pharmacology, Colin Dollery, who was an expert in high blood pressure. So they were not doing much research on asthma. But I was lucky to be able to work with Neil Pride, who is the head of the respiratory department. And I decided to work on the pharmacology of asthma and to look at the adrenergic system, because very little work had been done on this. And at the time I went there, they just developed an assay to measure adrenaline in the blood. And although adrenaline is well known, it was very, very difficult to measure, but they'd actually developed some very sensitive assays, so we could look at the plasma adrenaline levels. And we thought that people with asthma might have high adrenaline levels because adrenaline is a bronchodilator produced by the body from the adrenal glands, and that might be working to reduce the amount of asthma. In fact, what we found was that the adrenaline levels of people with asthma were normal. But whereas in normal people, on exercise, the adrenaline levels go up, in the asthmatic patients, the adrenaline levels didn't go up on exercise, suggesting that they were not able to mount an adrenaline response to a stress.
Right.
And we thought that that might be one of the mechanisms that was making asthma worse. And of course, we overcome that in the treatment of asthma by giving beta adrenergic agonists, which stimulate beta-2 receptors that are endogenously stimulated by adrenaline. Actually, I should say epinephrine, but we call it adrenaline in England. But I think we're changing.
We'll stay on your side of the pond for the interview. It's fine.
Okay, so this was a sort of new area because people hadn't looked at it before, and that got us into looking at beta receptors in asthma. As one of the surprising observations that was made is that when asthmatic patients are given beta blockers, they get worse.
Right.
And this is still not completely understood, but we thought it was because the beta blockers were blocking adrenaline. And so this was something we started to look at, and to also look at the number of beta receptors. And around that time, they had just developed assays to measure beta receptors using radio-labeled beta blockers, which allow you to directly measure the sensitivity and the number of beta receptors in tissue. In fact, Bob Lefkowitz last week got the Nobel Prize in chemistry for his work on beta receptors. So he was a leader in this field. But these were newly described assays called radioligand binding assays.
Right.
And we used these to look at beta receptors in the lung, and we looked at the number of receptors and whether they were different in asthma. And in an experimental model of asthma, we found that there was a reduced number of beta receptors. So this could be one of the reasons why asthmatics could be more susceptible to beta blockers, as well as the fact that the adrenaline levels may not be going up to defend beta receptor stimulation. So after that, I was looking at other receptors and linked to other assays. So we became interested in inflammatory mediators like histamine and leukotrienes, because we could also measure them in the blood and also look at their receptors. So that got us to be interested in the whole inflammatory process.
Right.
The inflammatory cells like eosinophils, mast cells, and the pharmacology of these cells. And so we really got interested in the whole area of inflammation in asthma, and we're able to show that it was present even in people with mild asthma, and that steroids were working by suppressing the inflammation. Because steroids had been used for a long time in asthma therapy, but no one really understood how they worked.
Right.
So we really started to address the issue of how steroids were having anti-inflammatory effects, what they were doing to inflammatory cells and mediators. And I think as a result of this research, we recognized that people needed to be using inhaled steroids much more in asthma, because this was a disease that involved inflammation of the respiratory tract that was normally steroid responsive. So that led us to really promote the use of steroids. And I must say, I had a lot of trouble with my colleagues over this. They thought this was very irresponsible to advocate the use of inhaled steroids for people with mild to moderate asthma.
From a side effect profile?
Because they thought these were dangerous drugs, that they had side effects, and that people with mild asthma could be treated just with bronchodilators. But we now know that we should treat all asthmatics with inhaled steroids, and that treating people with bronchodilators alone is inadequate. Right. And in fact, sometimes they're getting worse because you're not dealing with the underlying inflammation. So, as happened several other times in my research career, you find that when you're promoting new ideas, there's enormous resistance from people. But then eventually people adopt these views, and then they don't remember that they were ever opposed to them. So I think this is a very common pattern of behavior.
I've always found it fascinating for a profession that prides itself on its ability to review data and constantly be learning how dogmatic we become as a profession, it seems.
No, I think we need to keep an open mind, but also we can make mistakes. I mean, there was a particular mediator that we were very interested in called platelet activating factor, and it really accounted for a lot of the features of asthma. I mean, in animals you could give them PAF, and they got airway hyperresponsiveness and eosinophilic inflammation. And it was very similar to the features of asthma. And you could actually get PAF, you could buy it. So we were studying the effect of PAF on cells like eosinophils. Yeah. But because we had it available, we decided we'd look at what happened when we inhaled it. And it's very difficult to do these kinds of experiments these days, because in those days, the ethics committees were much less rigorous. And I think they even didn't require any permission to study normal people, which we counted ourselves as normal. So I was the first person in the world to inhale PAF. And it was quite remarkable. I mean, I had asthma as a child, and it brought back exactly the same syndrome as I had when I had asthma. And after one inhalation, I got wheezy, and then it recovered. And then I got wheezing for several days afterwards, and my airways became highly reactive for several days. So we thought, this is it. We've got the cause of asthma. So various pharmaceutical companies were developing PAF blockers at this time. So our idea was that PAF blockers would really be a fantastic treatment for asthma. So we had one of these early blockers and showed that it blocked PAF in the skin, for example, but it had no effect on asthma at all. So it was very disappointing. And then an even better one came along with the same results. So it shows that you can be misled by data, that it doesn't always predict which treatments might be effective. And I think you could say the same of other mediator blockers like antihistamines, which have never been of clinical benefit in asthma. Although we know that histamine is a mediator that's increased in asthma and produces many of the effects of asthma, like wheezing. And the reason, of course, is that there are many mediators,
Right.
and they interact with each other in ways that are very difficult to understand. So that when you specifically block one, other mediators can compensate for
This
that. And
seems to be a workaround.
And it certainly turned out to be the pattern for treating all complex diseases, including COPD, as we see in more recent studies. So after the work on the adrenergic system, I also did some work on cholinergic reflexes, and actually cholinergic mechanisms are still regarded as being very important in COPD, but more recently also have become seen as important in severe asthma.
Right.
So anticholinergics clearly have a place in asthma as well as COPD. But I then got interested in neuropeptides, because around that time in the late 1980s, there was a lot of interest in the role of neuropeptides in various diseases, because several neuropeptides had been found in autonomic nerves, and they accounted for some of the non-adrenergic, non-cholinergic neural mechanisms that had been described. And a lot of work had been done in the gut, in the brain, in the cardiovascular system. So we decided to look at the role of neuropeptides in the airways.
Sure.
And we know that there are neuropeptides in the airways, and we worked very closely with Stephen Bloom and Julia Pollack, who were also at Hammersmith Hospital, who were really world leaders in neuropeptide research. So this was very helpful. So we were able to show the presence of various neuropeptides in human airways, and that neuropeptides had effects. Some were bronchodilators and some were bronchoconstrictors. So we thought that these mechanisms may be important in asthma, and some other groups had shown that a neuropeptide called vasoactive intestinal peptide was reduced in asthma, and others have shown that substance P, which is a bronchoconstrictor peptide, was increased in asthma. So we looked at some of these things, and I came up with a sort of new theory of asthma based on the axon reflex, where if you irritate a certain area, you then release neuropeptides like substance P, which cause an inflammatory response and cause vasodilatation. And we thought this might be a way of amplifying asthma. And indeed, we were able to show in guinea pigs that this axon reflex mechanism was very important in experimental asthma. But when it came to human asthma, it was very difficult to demonstrate this, because we didn't really have good ways to study it. And then people came along with substance P blocking drugs, and they were very disappointing. So they didn't work in human asthma the way they worked in animal models of asthma. So again, it's another example of how a nice theory is often disproved by doing studies in humans.
Unfortunately, sometimes dashed at the clinical medicine side, right?
So humans are very, very complex. But I still think axon reflexes are playing some role in severe asthma as an amplifying mechanism, and they've certainly been, these mechanisms have been demonstrated in the nose, where it's easier to do the definitive studies.
Right.
So after that, we got interested in another neurotransmitter, which is nitric oxide.
Right.
And nitric oxide is a gas, but it's also an important mediator. So it's produced by certain nerves. And we were able to show for the first time that nitric oxide released from nerves in the airway accounted for the neural bronchodilator response in humans. So it was clearly involved as a mechanism that was beneficial to asthma. Right. And we showed that it was defective in asthmatics. So this may be one of the reasons why asthmatics get more bronchoconstriction. But nitric oxide is also produced by inflammatory cells, and it's a potent vasodilator. So as well as being a good mediator that relaxes airway smooth muscle, it's a bad mediator in a way because it causes vasodilatation. And increased nitric oxide is a feature of chronic inflammation. And because it's a gas, it gets into the airways, and you can measure it in the breath. And someone from Sweden had shown that you could actually measure nitric oxide in the breath of animals, and they also had one human where they showed it could be measured. So we decided to explore this, and we found that the nitric oxide levels in the breath were markedly increased in people with asthma, which we took as an showing that there was inflammation going on in the airway. So this could have then serve as a very valuable biomarker of inflammation.
Sure.
So we did a lot of studies looking at what regulates the levels of nitric oxide in the breath, and we showed that the way that you measure it is very important because its levels depend on the flow of breathing out, so you have to control the measurement very carefully. And then we measured nitric oxide after allergen challenge in people with asthma and showed it went up during the late response, which is the inflammatory response to allergen. And most important, we showed that it went down again with inhaled steroid treatment. So it was able to demonstrate the anti-inflammatory effect of steroids. So we did a whole number of studies looking into this, and at the time people were extremely critical of this because they thought this was far too simple to measure anything as complicated as inflammation. And so we had a lot of arguments, and it was very difficult to get the papers published because people were very skeptical. But now it's one of the most widely studied measurements of all time in respiratory medicine, and it is finding a useful place in clinical practice. For example, monitoring whether patients are using their inhaled steroids. It's able to distinguish between asthma and COPD because COPD patients don't have an increase in nitric oxide. It's very useful for looking at people that have unexplained cough, because if the cough is due to asthma, then you have a high NO. So there are many ways that measuring exhaled NO is now being found useful in clinical practice, and of course it's now much easier to measure it than in our time because there are portable analyzers that are very easy to use. So nitric oxide, I think, is still a very important area, and there's a lot of research going on still into that field. But at the same time, we started to look at other markers in the breath that might tell you about inflammation or different types of inflammation. So we looked at carbon monoxide, which is increased in asthma, but turned out not to be so useful because there's so much carbon monoxide in the atmosphere from car exhaust and from cigarette smoking that it turned out to be too noisy.
Too noisy.
Yeah. So we then started looking at volatile hydrocarbons. So ethane we found to be increased in asthma and COPD, and really as a marker of oxidative stress in the lung. And that led us to study exhale breath condensate, which basically is just collecting the breath in a cold surface, and you collect the fluid and analyze it for mediators. And we could show that various mediators were increased in asthma and COPD and in cystic fibrosis and lung fibrosis. The problem with that technique is that you get a lot of dilution because basically you've got steam coming out, and so there's variable dilution. So it's a more variable measurement than nitric oxide, but many people are still working on this. And then I suppose the major area that I've evolved into is COPD, because I'd spent, I suppose, the first half of my research career, which started in around 1978 on asthma, But the second half of my research career I've spent mainly on COPD, because it's such an important disease and we have such poor treatments.
Right.
And basically it had been grossly neglected. There was a huge amount of research in asthma, and asthma was very profitable to the pharmaceutical companies, so there was always a lot of research funding available, and many people were involved in asthma research, and it's a very satisfying disease to treat because you could make people back to normal often.
Right.
Whereas COPD is much more frustrating because people only improve slightly,
Right.
and they tend to get worse with time. So it's a very different sort of disease, and very little research had been done other than physiology research. So we decided that a very good approach would be to use the same sort of methodology that we developed for asthma, looking at inflammatory cells, mediators, mechanisms, and applying those approaches to COPD. And so we did a lot of work on induced sputum to look at inflammatory mediators, inflammatory cells. We looked at exhaled breath, and we looked at peripheral lung tissue that was obtained from lobectomy specimens that gave us peripheral lung. And taking all these approaches together, I think we really got a much better insight into the underlying mechanisms. I think the most important contribution has really been highlighting the key role of alveolar macrophages in COPD, because these cells are really playing a critical orchestrating role through the release of mediators that bring in circulating cells like neutrophils and T lymphocytes, as well as monocytes that then differentiate into macrophages. So we looked into monocyte differentiation. We also have more recently been looking into the phagocytic function of alveolar macrophages, and find that it's markedly reduced in COPD patients for phagocytosis of bacteria. And we think this is the main reason why COPD patients get chronic bacterial colonization, which is probably a very important feature of the disease, because these bacteria then drive chronic inflammation in the lung, but they also can flare up as bacterial exacerbations. So we found that these alveolar macrophages have a very poor phagocytic uptake of Haemophilus influenzae, for example, which is the main colonizing organism. And we've now found that this is something that you can also see in macrophages that you develop from circulating monocytes, which suggests that it's a fundamental feature of the disease, because these monocytes have never been in the lung, so that they're in some way start out as abnormal. And we've been able to actually understand the mechanism of this defective phagocytosis, which is due to instability of the microtubules due to abnormal acetylation of tubulin. So we're really working on this quite hard now as a way of trying to find new drugs that can restore phagocytic function. And we can already do this with microtubular stabilizing drugs, although at the moment these are a bit too toxic to give as a therapy. But at least we can show that this is a potentially reversible process.
Are you finding that this is something that is genetic and inborn, or is an acquired defect?
Well, this is a very important question, and we absolutely don't know, but this is one of the
Give me your best guess,
questions.
Because I'll trust it.
Well, my best guess is that it's probably due to epigenetics rather than genetics. But you know, only 20% or so of smokers develop COPD.
Right, that's our dirty little secret.
So there's something about now, people don't like to talk about it.
No, it's our dirty secret. We want everyone.
So we don't like to say that 80% don't get, although they do get heart disease and lung cancer.
Right.
So it's not
the smoking will get you anyway.
Smoke.
Yeah.
So anyway, there's something in these people that is making them susceptible.
Right.
And we don't know what it is, but we speculate that it could be this defect in phagocytosis. And that could be inherited, but I must say the studies on genetics of COPD have been very disappointing. Yeah. I mean, they haven't come up with anything. I mean, apart from alpha-1 antitrypsin deficiency, which we already knew, right, and is a rare form of COPD, they haven't come up with any really strong genetic mechanisms. So our guess is that it may be epigenetic, where the genes are changed by some environmental factors that may happen early in life and then are abnormal subsequently. Okay. But that needs to be investigated.
Sure.
But the other big area of research, which really spans asthma and COPD, is steroid resistance. And I'd say of all the research I've done, this is the area that's of greatest potential therapeutic relevance. We know that some asthmatics have a poor response to steroids. Right. And a very small number of asthmatics are completely resistant to steroids. And these patients are the ones that have severe asthma, right, which is why they have severe asthma probably, because otherwise they'd be treated with steroids and would be better. But these steroid insensitive patients have circulating cells that don't respond to steroids. So at least you can take these cells from the blood and they have a poor response to steroids, which means you can study the mechanisms. So we did a lot of work in steroid-resistant asthma looking into mechanisms and found that there are abnormalities in the way steroids switch off genes and switch on genes. And that work is still going on, but COPD, of course, almost every patient is steroid resistant, right, which is why we find it such a difficult disease to manage in the clinic. We commonly treat people with high doses of inhaled steroids, although most of them don't show any benefit. And the only ones who really benefit significantly are the patients that have asthma and COPD that have a high eosinophil count in the sputum. So most COPD patients are steroid resistant.
Right.
So we wanted to know why they're not responding to steroids, which means that we had to first find out how steroids work in the first place in order to find out what was wrong in steroid resistant patients. So after a lot of research, we discovered that steroids work in a very specific way to switch off activated inflammatory genes by recruiting a single enzyme called histone deacetylase 2, which reverses histone acetylation. Okay. So switching on inflammatory genes involves acetylation of core histones, which are the proteins around which DNA is wound in the chromosome structure. Right. And to switch on a gene, you have to open up the chromatin structure, which means that you have to acetylate these histones so that DNA becomes available for transcription. So it's a bit complicated, but right, the concept is not so difficult to understand. So when you give a steroid, it's binding to glucocorticoid receptors, which are in the cytoplasm, and they go into the nucleus and seek out activated inflammatory genes. They know exactly which are the genes to go to. And then this glucocorticoid receptor acts like a molecular magnet for this enzyme called HDAC2, which then comes in and reverses the acetylation. Right. So it shuts down the inflammatory gene. So when we give steroids to people with asthma, we're actually switching off all of the activated inflammatory genes, which is why people get better. And why no other treatment is as good, because once you give specific treatments like anti-IL-5, that's only going to block the IL-5 right, mechanism, but steroids block all the inflammatory genes. But they don't do that in these people with steroid-resistant asthma. And they don't do that in COPD. Right. And we found that the reason in COPD why they don't do it is that this HDAC2 is markedly reduced I mean, in severe COPD, it's only 5% of the level that you find in normal lungs.
Wow.
So it means the steroids are not able to switch off these genes, but it also means that the normal mechanism that terminates the inflammatory gene activation is missing. So these genes, once they're switched on, don't get switched off. So it means the inflammation is much worse, which is exactly what you see in COPD compared with normal smokers who have the same inflammation but much less intense. So this HDAC2 is pretty important. And then we go back to asthma, and we find that some people with severe asthma have a low HDAC2, but not all, because there are other mechanisms in asthma. But the most interesting example, I suppose, is smoking asthmatics, because asthma should respond to steroids, but in asthmatics that smoke, the steroid response is lost. And that's linked to reduced HDAC2. And so the mechanism for this reduced HDAC2 we think is oxidative stress from cigarette smoking, or from endogenous oxidants coming from inflammatory cells. So we can artificially cause steroid resistance in cells by exposing them to oxidative stress. And then this really reproduces the findings in the cells from severe asthma and COPD. And we can actually reverse this process by transfecting the cells with HDAC2, which can artificially boost the levels back to normal. And then they become steroid responsive. So this is a very important observation, because it shows this is a potentially reversible mechanism. Now, the amazing thing is that we found that an old cheap drug did the same thing, which is theophylline. So this observation was made by my colleague Kaz Ito, who really runs this research in our department. And what Kaz said is that when we measure this HDAC activity in patients, we need to see if any of the drugs they may be treated with might affect the assay.
Sure.
And most things had no effect, but the treatment that had a marked effect was theophylline, which we were still using in people with severe COPD because it's a useful add-on therapy. And it turns out that theophylline can activate the HDAC2 back to normal and completely reverse steroid resistance. And we've worked out the mechanism that theophylline does this, and it's through inhibiting an enzyme called phosphoinositide 3 kinase delta, which is in the pathway that links oxidative stress to reducing HDAC. So it's a logical target. And theophylline inhibits this and reverses the process. So it means that we already have a drug that could actually resensitize people to steroids. The problem is that theophylline is cheap, and no pharmaceutical company wants the studies to be done, of course. But also academics are very skeptical, because they say this is an old drug, and if it was that good we'd know. But actually you would never know until you do a clinical trial. So it's taken many years to get funding, but we're just about to start a large trial in India and China looking at low-dose theophylline, and another study in the UK looking at low-dose theophylline in COPD patients, because I think this is going to be a valuable treatment in the future.
That's fantastic. You know, one of the things I'm struck by as I was listening to you, and there's obviously an underlying theme and focus to your work, but what I was also struck by, especially for anybody who's very earlier in their career and listening to this and watching this, is as how your research evolved as other things were coming out as well. In other words, you know, other people are clearly working in this field or neighboring fields, if you will, and wow, here's a new way that cells are communicating. Maybe let's explore this in asthma. And that, you know, it was the adaptability and your own evolution as a researcher that, you know, kind of always kept you on that cutting edge. And I think we said it earlier, the ability to adapt and to engage in new thoughts and see where they take you.
No, I think that's a very important approach, Kyle, because there's a lot of knowledge in other areas outside respiratory, and in many areas this is more advanced. I mean, we talked about GI before.
Right.
And, you know, they were very advanced in neuropeptide research,
Right.
for example. So we had a lot of previous knowledge from the work they had done. And, I mean, I think that's certainly been true in regulation of genes, because most of this work has been in the cancer field.
Right.
And so we've got a lot of valuable information from the work that's been done in cancer cells and looking at therapies. In fact, they're trying to do the opposite in cancer, is to inhibit HDAC, whereas we're trying to stimulate it back to normal. But I think you can learn a lot from looking at other disciplines. And one of the problems about modern science is there's too much of it in a way. And we don't have time to go to GI meetings and cardiology meetings. Right. And as you may remember, FASEB used to cover all areas, but now FASEB has really been split into pockets because there's just too much knowledge for everyone to go to. So in the old days, people could learn about cardiovascular and cancer, but it's very difficult for us to do that. I mean, I think we're lucky in respiratory is that we reach into many different other areas of internal medicine, like cardiology, endocrinology, neurology.
Right.
So we're probably more connected than other specialties with different areas of internal medicine.
So how about this? Give some general advice as well, on not just from a research perspective, but also for someone, again, in various stages of their career, on how to be such an effective mentor. Because, you know, I'm struck as you were going through all that research, and it clearly meant that you had an army of people that you were working with, collaborating with, helping to guide, and people who have equally have had, I'm sure, unbelievably successful careers by working directly with you. I mean, that level of mentorship is valuable in its own right, besides the work you're also doing. So I'd love to hear advice from you on what did you take away as you were being mentored, that you absorbed, that you would love to see others grow and develop as their careers move on?
Well, I must say that during my career, I've been very lucky in the people that I've worked with. I've had some wonderful fellows who've gone on to become world leaders in respiratory, and they now send their fellows to come and work with us. And so we have a lot of connectedness in different areas of the world. And I myself actually spent a year in San Francisco working in Jay Nadell's lab, which was enormously valuable for meeting people that I'm still friends with, that we worked with all those years ago. So one of the things I've always encouraged is for people from overseas to come and work in our lab. And we've had some really outstanding fellows from all over the world, I'd say, who then go back to their countries and set up research, and they may send people back, or we send people over there. So I think connecting people is a very important thing, because you learn much more by talking to someone than reading an article they wrote. Right. Which of course is the value of meetings like CHEST and ATS, ERS meetings, that you meet people. I think what I try to do with our fellows is give them lots of time for the research, so we don't involve them in endless meetings. So they actually have time.
Look right at the camera and say that again.
Yeah, well, meetings destroy research. Do
you hear that, every section chief out there?
You don't want to have too many meetings, but it's important to have research meetings where people present their. So we have a weekly meeting where people present their research in rotation, so everybody knows what everyone else is doing, and then they can see who they can work with, because some people have an assay that could help their research. So I think spreading knowledge within the researchers in our group is a very important thing, but not encumbering them with lots of meetings and courses and things. I think for clinical researchers, it's very important that they continue to do 1 or 2 clinics a week, because they need to stay connected with clinical medicine. And in fact, I mean, that's important for a practical sense in terms of recruiting patients for
Right.
studies, but also just to keep thinking about the clinical questions.